First of all, I'm thankful to Sanaullah Junejo, the Health Asia, and all the organizers for making this possible. Something I think the, a useful meeting is where you go and you have a take-home message with you. And I think that is a great achievement of any meeting. And I think that's been accomplished today because I'm going home at least taking the message that we can fast track our patients, we can improve their satisfaction level and also cut down the cost of their treatment. The major consideration in our country and anywhere for that matter. Dr. Mangi, he paved the way on ERAS topic, and I think I agree with him when he showed about Nokia, that few years ago everybody would love to carry a BlackBerry in the pocket. But how many of us have got BlackBerry in our pockets today? Anybody? No. It's all shifted to iPhones and Samsung and touch phones. So I think this is progress. And if you stay with one thing, then you become a dinosaur. You have to adapt, you have to change, and you have to be cognizant of what is coming next and position yourself accordingly. When I was a medical student in 1970s decade, we used to admit hernia and keep them in hospital for 10 days. That's not the case now. They come in the morning and leave in the evening. When I started cardiac surgery practice, and Arif Saab will, I think, echo my words, that with the bubble oxygenator, we used to see every patient coming back. You go in, take a patient to operating room 70 kilogram, and they would come back 80, 85 kilogram, and with wet lungs and pump lung, and oxygenation used to be a difficulty. Now we seldom see those things. So I think that over a period of time, things have progressed, and we have to move on with that. Then Shahab explained very well the elements involved in ERAS, followed by Dr. Tariq Azam, who gave the global perspective of ERAS, and he gave the example how the cycling team of England got there by making small adjustment and taking care of everything. और उर्दू में कहते हैं कतरा कतरा दरिया बनता है. मेरा ख्याल है अगर हम यही अडॉप्ट करें कि छोटी छोटी चीज़ों पे तवज्जो दें तो बहुत सारी चीज़ें कलेक्टिवली हमारी पेशेंट की आउटकम इम्प्रूव कर सकती हैं. मुनीर अमानुल्लाह, fabulous presentation on ERAS, on extubating patients in the operating room, and certainly that should be the way. But how to achieve it is important. The thing is that here you have to have a very good teamwork. You are pulling down the patient, you have to rewarm the patient, at the same time you have to rewarm the whole operating room, and if the whole flow of things is there, you can achieve a lot. And those results were indeed admirable. One word of caution. I was reading recently early discharges from the American hospitals. Now we have to take it very cautiously because some of the discharges are in the halfway house, which are to the places which are close to home. So if somebody is coming from Dadu, then hospital can make arrangement for these people to stay closer. By sending them there, you cut down the cost of hospitalization. At the same time, they are closer to your facility. So that is something to consider for big centers like SIUT, for AKU and other big NICVT for that matter. So I think that one should explore that. Dr. Niaz So, bro, I really enjoyed your presentation. And I think if you look back at the history, and your last presentation also had, your last reference also had this name. Then it was Ole, and there was another person, Ferron. These were two surgeons, and they were actually attending a conference in London on nutrition. And from there, they coined the term ERAS. And for those interested, you should go to a site called erasociety.org. They came back and they formed this society in 2010. For the first time, as we now know, that it was introduced in Boston in 2017, but the first definitive paper on ERAS in cardiac surgery was published in JAMA in 2019 May. And since then, it received a lot of attention, and I think that this is the way forward. And clearly, the take-home message is that yes, we need patient satisfaction, yes, we have to cut down the cost, and we can adopt these things which are going to make life easier for our patients. But there is fear. If I ask in any surgical meeting to raise hand for those who continue to give antibiotic beyond the prescribed prophylactic duration, then some hands are there, because they fear that in our setting we have infection, high rate of infection, we have warm climate and everything. But it's not so. I've been for last 25 years restrict my antibiotic use to 48 hours or whenever CVP line comes out, and I do not see any profound or major complications of infection. So thank you very much in the end.